Good afternoon, everyone. To begin with, we will not be taking questions today on the Heart of Illinois North Central Subregion Plan. As many of you are aware, on Thursday's briefings, I do not usually attend. However, I did want to stop in and clarify some of the discussion that we're getting around Restore Heart of Illinois. Elected officials are in local committee meetings currently, as well as waiting for feedback from the governor's office and the Illinois Department of Public Health. Just a reminder, this plan was submitted to the governor's office and the Illinois Department of Public Health last week and is still under review. Our region, along with the rest of the state, continues to operate under Phase 2 of the governor's Restore Illinois plan. However, as we did mention yesterday, the operations moving forward does take time for us to gear up. It requires us to build out a website for our subregion, create protocols and guidance for our local businesses in terms of how to comply and what restrictions that they will be needing to take to meet the best practices of the CDC, as well as other standards within their industry. And as well, there is a large aspect of coordinating data amongst all the 4 capabilities we listed: healthcare, public health, our PPE levels and mitigation, as well as community engagement. This takes time for us to do. It's not a switch on overnight. So please, with that in mind, we do recommend that take the time to review the Restore Heart of Illinois plan, as it identifies a phased-in approach that we submitted for review to the governor's office and the state of Illinois, as well as take a look at the Restore Illinois plan as well to prepare yourself for the eventual reopening of our community. Again, we want to make sure that we're providing the best support in terms of protocols and procedures to keep our community safe and healthy. If you do have any questions or want to know how to access this information, the presentation as well as the slideshow are available at the websites for the Peoria County Government, the City of Peoria, as well as the Peoria City County Health Department. So with that, I'd like to introduce our next speaker, which is the Medical Director for the Peoria City County Health Department, as well as Heartland's Chief Medical Officer, Dr. Gregg Stoner.
Thank you, Monica. I'll share with you today's information. The first daily count is that we have 149 confirmed cases in Peoria with 6 deaths. 58 Tazewell patients are confirmed with 3 deaths overall, and 15 Woodford County patients with 1 death overall, for a total of 222 total patients confirmed with 10 current deaths.
I'm sorry, could you repeat the total for each county again, just the total?
Sure. Peoria was 149, Tazewell 58, Woodford 15, for a total of 222 positives, 6 deaths in Peoria County, 3 in Tazewell County, and 1 in Woodford County, for a total of 10. 73.4% of the Tri-County cases are recovered. 17.6% of Tri-County cases are at home isolating, and 4.5% of Tri-County cases are hospitalized. We've only had 1 new case in the whole Tri-County area yesterday, as well as our 7-day and 14-day trends are decreasing for both ICU and total number of cases. The total number of ICU beds in use right now are 9. Persons under investigation in ICUs are 2, and confirmed patients are 7. Non-ICU beds in use are 25, and there have been no deaths in the last 24 hours. The data from Heartland's testing at our collection sites, yesterday we had 446 specimens collected between Peoria at our East Bluff site and in Pekin that we opened yesterday. We'll be open now on Mondays and Wednesdays. One thing I've been asked to mention is the response that we've had at the shelters and how that has gone. We've seen something quite unusual with the mobile vans going to the shelters. And for instance, at one shelter that we went to on Monday, there was just 1 person that wished to be seen. They normally have about 60 people that reside there. And I asked why the numbers were so low, and they said that their total number of people being housed at that center was about 1/3 of what they normally had. When I asked why that was, They said that it's because we're going there and testing people, and that people are afraid of having the test done, afraid of finding out the results of those tests, and afraid of what would happen if they were found to be positive. They did not want to be isolated if they were found to be positive. They were afraid that the test would be painful. And the other factor in that was also that they are apparently listening to a great deal of social media out there and hearing all sorts of conspiracy theories about this all being a hoax, and that this really doesn't exist, and that it's all politically made up, and there's other people trying to cause problems for them, and that they'll be subject to a vaccine that might hurt them, and all sorts of other conspiracy kinds of thoughts out there. So we really want to dispel those things. I mean, we want to test as many people as we can. We think that it's important for opening up our community, and so that we can all get back to as normal as possible, and we encourage people to be tested. So thank you. I'd like to introduce Dr. Ralph Velazquez from OSF. He's the Chief Medical Officer for OSF Healthcare, to talk about elective surgeries.
Good afternoon, and thank you. For many of you, you may be aware, starting Monday throughout the state, elective surgeries were started again in many of our hospitals as well as ambulatory surgery centers. Those elective surgeries here in Peoria at St. Francis are less than half the volume that we normally do. When I'm speaking about elective surgeries, we're covering both surgeries that are done in our operating rooms, things that may be done in a catheterization lab, or things that are done in interventional radiology or gastrointestinal endoscopy labs. So less than half of the normal volume so far this week. That was intentional. There have been a number of changes we've done to try and make the environment even safer for patients. So by reducing the volume, it allows us to test these new changes that we've implemented. Because as Dr. Stoner was mentioning, fear is growing. It's been growing, and we want to make people feel safe when they do come in for surgery. Because of the delay, we apologize for many patients who've been suffering, who've had to put off their surgeries. But now we're trying to get them in and get them in a safe environment. There have been some significant changes to make that environment safe. We continue to be diligent regarding disinfection. That hasn't changed. But what has changed is some of the process of coming in for surgery. Many hospitals are adopting what we call a kiss and drive type of approach, similar to what we see at airports, train stations. You drop off your loved one, they are met at the door in the parking lot, they are brought in, they are taken up to the surgery prep area, quickly going into surgery, having their procedure done, recovered. As once they've recovered, a call is made to your loved one to come pick them up, back out to the parking lot, delivering your loved one back to you, then giving you, the family members and the patient, the instructions for discharge and for proper postoperative care. So that's a new process for us, and that's why the lower volume helps us get that right. Another component of that is creating parts of the hospital that are called non-COVID care zones, NCCZs. These are zones where there would not be any COVID or COVID suspected patients. So we have been cohorting patients into a specific zone with dedicated staff taking care of COVID patients in those zones, but now we have other elevators, we have other sections of the hospital that are strictly non-COVID care zones. So those who are caregivers in a COVID zone do not come into the non-COVID care zone. So that's another step that we've taken to make the areas safer. One thing I like to do is also show some appreciation for the people who have been coming to the hospital wearing masks, bringing their own mask. It's critical that you do that because we do not have an unlimited supply of masks in the hospital. We are also continuing to screen all of our mission partners as they come to work with temperatures and questions, and we screen all visitors with the same thing, temperatures and questions. We also would like to mention that we are dedicated to keeping the area safe. Within OSF I imagine also other health systems, we are doing tracers. What I mean by tracers are, we have trained our staff on how to put on the protective equipment, the masks, the gowns, the gloves, how to clean their hands. A tracer means we have somebody watching them to make sure they're doing it right. And if they're not, going back and doing some additional education. So we're doing that to keep our mission partners safe and to keep you safe as patients. So we will continue to do that. Also, what we're doing is we are tracing for universal spread control. That means looking around and making sure people are wearing masks and that they're wearing masks correctly. And in this room, for those of you who can't see, everybody's wearing their mask correctly. They are covering their nose, they're covering their mouth. If you see people out in public with their nose exposed, I see a number of people just driving here with the mask under their chin, doesn't help. So wear the mask correctly. And that's what we're doing. We're internally holding each other accountable. I need to protect you from getting it from me, and I need you to protect me from getting it from you. Any questions? Yes.
So could you discuss, as we talk about reopening plans, not only locally but on the state level, how the hospital's preparing for, potentially, more cases coming to the area?
So the hospitals are keeping surveillance with the work that the county health departments are doing with the testing. We review that information as it's being refreshed on a daily basis to see if the numbers are going up. We're also monitoring the number of patients who come into our emergency rooms with influenza-like illness to see if that's going up. If that's going up as a percentage of all the patients coming in, those seem to be early indicators to us. Some of the work we're doing from a pandemic healthcare worker standpoint, where patients are calling in with symptoms, we're also tracking those numbers to try and give us early indicators that something will be happening. If we start to see things moving in the wrong direction, that we may be getting another hotspot, then we will have to make adjustments regarding those elective surgeries, whether we stop them or reschedule them.
When you say you're taking at volume, can you quantify that, put a number on it? How many fewer people is it than usual in the time before COVID, essentially?
So far this week, I believe, as of this morning, we had 77 elective surgical procedures. Now, there are procedures that are going on for people who are sick in the hospital who need a procedure. That's not elective. But 77, we're anticipating even next week, maybe 140, a little over 140. So the number is dramatically less than half of what we would normally do in a week.
Did you say you would normally do 140 and now it's in the 70s, or can you repeat that? I'm sorry.
It's 70s within the first 3 days of the week. Next week, we have already 140 scheduled. I would also like to take some time. Each hospital has a surgical review committee. So a group of surgeons who look at the cases and say, is it necessary to do this now, or can it be delayed? So they're reviewing the cases so that they can have a peer-to-peer discussion whether something needs to be done now urgently or it can be delayed.
Can you
So,
give an example of what's urgent and what's not urgent?
okay, some examples of urgent. You may have a condition that's causing severe pain, severe back pain. You may have severe disc injury. You may need to go in for back surgery because you're already getting numbness down your leg. You may have a cancer diagnosis that's been detected by imaging, and we want to get that out. It may be compressing another organ. That may be something that we're going to do right away. It's urgent. And that's what was my reference to patients who've been suffering. Does that help?
Were those just the ones that are urgent?
Those are some of the ones that are urgent. There's a whole host of other types of urgent cases. Many of the societies, from the American College of Surgeons, has defined specific cases.
Do you have an example of those that aren't urgent, like that people might think, hey, I need to come in, but it might not be urgent at this time?
Somebody may have a skin lesion that it's changed. The mole has changed. I want to know what it is. I got to know what it is right now. Probably not urgent. If you had a history of skin cancer, probably more urgent. So you have to apply it, and that's where we defer to those surgical review committees to help with those decisions.
I've got a couple for Dr. Stoner.
Sure.
Yes, Tim.
Doctor, you had said there were, and I forget the exact number, it was roughly 440 some odd yesterday between Pekin and East Bluff?
Yes.
Okay, so how many, what's the breakdown there? Because this was Pekin's first day open, so I guess I'm looking for a gauge of how well Pekin did.
They did very well. It was an exact tie, actually. It was 223 at each location. Kind of odd that it would be that way, but it was an exact tie. So we were supposed to do 150 at a site on a day. That was kind of supposed to be our maximum. But when there are people waiting in line, we go ahead and still see them.
So you've actually, is this kind of a case like when we saw this first roll out in Peoria, there's a lot of like pent-up demand? Do you think we're kind of seeing a similar effect in Pekin now?
I think so. It's hard to know how that's going to hold up over time. But people from Pekin had been coming to Peoria to get their tests early also. So we'd seen a fair number of people coming from Pekin already. So I'm sure is a pent-up demand in Pekin that we'll be meeting.
Dr. Stoner, you
Yes.
shared earlier during the conference about, kind of the spread of conspiracy theories and stuff and the negative impact, that can have. If you could share just, on a general level, just the sharing of that kind of misinformation and the detrimental impact that can have on a public health, crisis like this.
Sure. Well, this is, without any information like that, this is scary enough for people, thinking that they might catch a disease or spread a disease to a family member or loved one, and that it could be something that's devastating to them. On top of that, and that's with pure science information that we already know and accept. In addition to that, when you have people who are kind of generating things that are kind of more imaginary about conspiracies between different groups and anti-vaccination groups that are using this as a platform to discourage people from being vaccinated once a vaccine is developed, and not to be tested because that's part of this whole conspiracy to test people and register them and everything. It's really been detrimental to a lot of people, and it goes across all of society. It's not just one group that is subject to hearing that or believing those things.
Well, I've seen and heard, I guess, firsthand, like the videos, just circling back to what you were saying about the test hurting. I've seen videos of people crying. I've heard people say, oh, there's no way I'm going to get that test. I heard it hurts. I heard they have to stick the swab all the way up your nose. What do you kind of say to those people? Like, is that subjective? Is this test really invasive? Does it hurt, or is it just to each his own?
I'm sure it's uncomfortable to have it. Okay, it does go back through the back of the nose and hits the little kind of wall back there that you run into and take the specimen. And it takes about 10 seconds, so it's uncomfortable. Some people sneeze afterwards. Some people cough afterwards. Some people it brings a little tear to their eye. Okay, most people say, "Oh, it's fine," and they thank us for doing it when we get it done. And so we've only had, I think, 3 or 4 people out of nearly 4,000 people that have not really been able to tolerate it and not complete the test.
You talked about rates decreasing. Could you go into specifics about those numbers and kind of what that represents for this area?
Apparently the 7 and 14-day rates are decreasing. The rate that we're seeing in positivities overall in the tests that we've done is a little bit under 3% of the population that we're testing. That's both symptomatic and asymptomatic people. So that's been very encouraging when you compare it to national statistics, and some places that are 14.8 or 18.8% positive rates. And so we're well below the national average here in the people that have consented to testing, and that's quite a few people now that we've tested.
I got a question for you again. I'm
Sure.
sorry.
Yes.
Did you mention if those patients coming in for surgeries, is there like a mandatory testing? You have to be tested before you come into the hospital for COVID-19?
Yes, as part of the IDPH guidelines, they did give very specific requirements on testing. So patients who are going to have a procedure done in the main operating room, patients who have general anesthesia, or patients who are going to have what is considered an aerosol generating procedure. All of those patients must have preoperative testing within 72 hours before the surgery. And it must be negative before proceeding with surgery. Other questions?
Other questions? Okay, well, thank you all. That'll end the press briefing. Thank you.